So the next speaker will be Vanessa Raymond, who I have the pleasure of working with at the University of Oxford. Vanessa is a senior clinical researcher with a special interest in head injury. She has worked on a study in the US looking at the cognitive outcomes of veterans with head injury, and then has went on to set up clinics in neuropsychiatry of head injury while working at West London. And since joining us, she's been really spearheading efforts in dementia research. So I'm looking forward to Vanessa's talk.
Thank you, Ivan. Just going to share my screen, so hopefully this will work. Okay, so I've been asked to talk today about some potentially modifiable risk factors that could contribute to your risk of developing dementia, including head injury and alcohol. I guess I'm going to echo some of what Simon Lovestone has said about, although this seminar is about successes in dementia research, in terms of what we know about head injury and the risk of subsequent dementia, there's still an awful lot of work to do. Just to give a little bit of context about this, I just wanted to describe where head injury sits in terms of other potential brain injuries. So a lot of, you may hear on the news or in various forms of literature, people talk about brain injury, acquired brain injury, traumatic brain injury. Just to be clear, acquired brain injury is basically any injury to the brain that occurs after birth. And broadly speaking, those types of injuries can be split into ones that are traumatic or not traumatic. Traumatic brain injury is therefore inherently a form of head injury, so one equals the other. But there can be a whole load of other causes of non-traumatic brain injury, so things like infections, strokes, tumours, and also alcohol. In terms of traumatic brain injury, so head injuries, we broadly split that group into whether somebody has what's called a closed brain injury or an open brain injury. And basically that means whether the skull itself has been penetrated as a result of the injury. But you can see from the lists on these on this slide that the causes of both of those types of TBI, as I'll shorten it to, are broadly the same. A few statistics about head injury or TBI. It's been referred to in the past as a silent epidemic. Again, like dementia, it's a massive public health problem. It's estimated in the UK, TBI is suffered about every 3 minutes, and approximately about 1 million people attend A&E within the UK every year. However, as you can imagine, a lot of people do not go to A&E or to see any doctor if they've had a more mild head injury, so they maybe have just banged their head somewhere at home. If there's not been any severe symptoms, they probably don't go and seek any kind of help, so that a lot of these are probably completely unreported. And of the people who do go along to be seen either by their GP or an A&E, 80% are discharged. So vast numbers of people will present, but will then be discharged with any kind of follow-up. What we do know about brain injury, or traumatic brain injury rather, and its risk for subsequent dementia is based on the people we actually see presenting to clinical services. So that's inherently going to skew some of our knowledge. Because of this, as I suggested, the vast majority of people who'd have a head injury have a mild head injury, and this may or may not lead to a concussion. So it's estimated about 3/4 of people who have a head injury, it will purely be a mild head injury. However, even allowing for all of this, head injury is actually the leading cause of death and disability in the over 45. So it's a massive problem, as I said, in terms of public health need. And it's estimated again in the UK, about 500,000 people are living with long-term disabilities. And worryingly, the amount of people at least presenting, or that we know about with head injuries, has increased quite dramatically, probably about 50% over the last decade, particularly in women. And again, I'll come back to that as to what that could mean. But again, like dementia as a whole, it does mean head injuries are a massive cost in a public health perspective, and probably equate to 0.5 of the entire annual global output. So because of this, people like the World Health Organization have identified TBI as a major public health problem with huge unmet needs. What this graph demonstrates is what may cause a head injury or a TBI. And along the bottom of this graph, you can see various ages, and then the percentage of TBIs are represented by the bars on the graph. So what this demonstrates is across the lifespan, the likely cause of somebody getting a TBI varies. So for the very young, it's mainly going to be falls. As you get a little bit older, Road traffic accidents, road traffic crashes become an increasing cause of head injury. And as you get older still, so in the over 60s, falls become the major cause of head injury. So not only are we talking about a group that don't always present for medical support or diagnosis or follow-up, we're also talking about a range of causes in this group. And again, that's obviously going to skew whether people seek help or attention after they've had any sort of head injury. What this cartoon tries to demonstrate is what happens when you have a head injury. And broadly speaking, whatever the cause is, whether you were in a car and involved in a crash that causes your head to swing back and forth in a kind of whiplash fashion, or whether you are falling from a height onto a floor, what happens is because of the momentum of your head and brain, there is a movement of your brain within your skull. So even if you have a fall and there is no fracture of your actual skull, there will be a movement, what's called a coup and contra coup injury to your brain, where your brain is basically shaken around in your skull. What that means is that if you sustain an injury as a result of a fall, or as I said, a road traffic accident, you're not just going to have one part of your brain injured. So again, this adds to the complexity of the types of problems people may develop after the head injury, but also obviously how those could lead into increased risk for dementia. So what does a head injury do? Well, as I said, the location can be anywhere in the brain, depending obviously on the cause of your injury. But as you could expect, frontal lobe, so the front part of the brain being damaged, is by far the commonest. That tends to be the way we fall, or the area that's most affected in road traffic accidents. And in terms of what we see, if we see somebody in A&E and we do a scan, we may see an element of bleeding or bruising or tissue deformity of the brain. But we are starting to understand that a huge amount of head injury changes, or things that happen in the brain after head injuries, are invisible. And actually, as I mentioned in this slide, maybe half to 2/3 of people will have a normal brain scan after a head injury, particularly mild head injuries. And what we're starting to understand is that some of the damage that we don't visualize in routine scans is actually there, and again, could be a contributor to long-term risk for dementia. And that the particular thing that's been focused on is the degree of axonal damage that head injuries cause. And this cartoon demonstrates what that means. So axons are the tail ends, if you like, of nerve cells, the projections of the brain cells that do the hard work in terms of our thinking capacities. And what happens when your brain is shaken within the skull, as you can imagine, is that those tail ends of cells will get stretched and at a certain point may break and split and tear. And that tearing tends to happen at the boundary that occurs between the grey matter of the brain. So that's the nerve cell bodies, as I said, the areas of the brain that look after all of our main thinking capabilities, and the white matter, which are the tracts between them, both equally important, but that boundary between the two is what's really vulnerable in a head injury. And this shearing, this tearing and stretching of the axons is the thing that currently we don't visualize in routine brain scans. So it's really hard at the moment to determine, when people turn up to A&E, have they suffered a degree of what we would call diffuse axonal injury. These two pictures demonstrate pictures of somebody's brain after death. The reason I put them up is because the little black dots on both of these pictures represent what are called traumatic microbleeds. So these are very small areas of bleeding as a result of some kind of trauma, some kind of head injury. And so in the past, we thought these represented the damage that you can't always easily visualize on a scan in A&E. But we're starting to understand that even these small areas of bleeding may not correlate well with the degree of axonal damage, this underlying stretching and tearing of axons that serve these tracts between areas of the brain. And this slide, what this demonstrates is a new type of imaging that's become common, certainly in research, which is called diffusion tensor imaging. And what this does is look at the orientation of water in the brain, and it allows us to visualize these lovely tracts. So this picture demonstrates a kind of green set of tracts that you can see, and it allows us to see where there may be breaks or changes in the structure of these tracts. So for the first time, we do now have a form of imaging that hopefully gives us some idea about this invisible damage that we haven't previously seen. the issue with this is the fact that this type of imaging is really only done in the research domain, because we still don't really understand how we interpret that in terms of clinical symptoms and prognosis after things like head injury. So at the moment, if you have any form of head injury, you will still have what we call a structural scan, either an MRI scan or a CT scan. You would not normally have a DTI scan like this. So coming on to the main reason that I'm here to talk to you, which is about the links between head injury and dementia. Well, to be honest, as Simon Lovestone said earlier on, we know there is a link between head injury and dementia, but exactly how that link operates is still a bit unclear. The fact that we know that people develop cognitive problems with their thinking after head injuries, we've known this for a long time. So there have been cases going back 50 years or more, particularly in people, for instance, former boxers who will often experience multiple head injuries, repeated head injuries. So we know there's an issue. What we're not sure about is whether it is a direct result of a head injury or whether this leads into a subsequent pathology that increases your risk of dementia or not, and what that looks like. More recently, we know that people with more moderate and severe head injuries, so these would be where there is a penetration of the skull, people lose consciousness, for instance, so these are the more severe injuries. The majority of those will report some kind of long-term thinking problems. And one analysis, what's called a meta-analysis, so this is trying to pull all the literature together, looking at all the papers that are out there, looking at this type of theme, in 1991 found that there was about a 1.8 increased risk for developing Alzheimer's dementia after a head injury. And in fact, when you look at those papers, it seemed that TBI was probably the most important factor only after things like age and family history, and what's called the ApoE genotype. So this is a genotype we know that is particularly linked to increased risk for developing Alzheimer's disease and dementia. But there did seem to be some interaction. So for instance, we know if you have this ApoE genotype and you have a head injury, your outcome may well be worse. It's also feasible that if you have repeated head injuries, or if you're younger when you have your head injury, that may again lead to a worse prognosis in terms of developing dementia long term. But this is a long process. So there's been a lot of studies recently done, particularly with this new form of imaging that I mentioned, the Dti imaging, that have demonstrated you can see changes in the brain decades after somebody has had their initial head injury. So you see levels of inflammation, and you see things like higher amyloid levels. And again, Simon mentioned that amyloid is one of the proteins that we see that's increased in Alzheimer's dementia. So we certainly know there are links going on, and we know that, as I said, consequences of head injury will continue for decades after. So at the moment, in terms of what we know, we estimate there's about a 1.6 increased risk for developing Alzheimer's dementia after a head injury, more commonly in men than women. Again, I'll come on to that a little bit later. And so that could equate to about 5% of all dementia cases. So it's not a small factor in terms of what causes people's risk for dementia. This is a very busy slide, and I'm not expecting everybody to read all of this or go through the details. But what this emphasizes is that head injury is just one factor that feeds into our risks for developing dementia or not. So again, as Simon and Ivan have mentioned, we know Alzheimer's disease starts several decades before anybody develops a clinical syndrome of dementia. And there are various risk factors that increase the risk of that disease progressing into dementia. And similarly, there are protective factors. So we know things like if you exercise regularly, if you stay active in terms of your occupation and education, all of these things protect against that progression. But TBI is certainly one of those risk factors that seems to interact with all these other things in terms of increasing your risk for dementia or not. But again, coming back to what I said at the start, it's still not clear. So on this slide, I've quoted a couple of other more recent studies which involved really large populations and looked at the data around whether head injury leads on to risk of Alzheimer's dementia. And actually both of them found no particular risk. And the reason these studies were important is because one of the issues around looking at TBI as a risk factor is the fact whether we are identifying everybody. So there's a problem sometimes with how we categorize TBI, how we identify it, who presents to doctors and A&E and so on. So it's not a clear picture. And just to touch briefly on other types of dementia, things as Simon mentioned, frontotemporal dementia, Lewy body dementia, and so on. The evidence is still very unclear. The one thing I do need to mention as we are talking about head injury is this thing called chronic traumatic encephalopathy, or CTE. And this was the first type of pathological change that was described back in the 1920s as a result of repeated head injury. It used to be called punch-drunk syndrome, or dementia pugilistica. What's interesting is that it was understood more recently that you see a lot of these tangles, the tau tangles that Simon referred to, in CTE as well as in Alzheimer's disease and dementia. So there's still a lot of debate. We don't really know whether head injury activates some kind of form of neurodegenerative pathway that leads to dementia, whether it accelerates other conditions, or whether CTE actually expands to other areas in the brain as time progresses, and that's the cause of an underlying dementia. So exactly how the changes that occur subsequent to a head injury, whether that feeds into this thing called CTE, and how that feeds into dementia is still very, very unclear. And this slide just demonstrates the similarities we see when we look at imaging of people with head injury and dementia. So this is a slide that shows people who have had imaging looking at tau in the brain. And you can see clearly there from left to right, we've got some control subjects, patients with Alzheimer's dementia, football players. So this is American football players who would be highly exposed to repeated head injuries, and people in the military, again, another very at-risk population. And what you can see is there's a lot of similarity there in terms of quantity of tau in the brain. So there's definitely some overlap, but as I said, still quite unclear how the two things are connected. I'm aware that time is ticking, so I may slide through a couple of these slides.
Yeah, Vanessa, if I could, because we're sort of just gone over the 15 minutes, would you like to sort of open to question after a slide or two?
Absolutely, yep. I mean, I think the main thing I want to emphasize, and I just want to say something very briefly about the alcohol component as well, as I said, is that how repeated head injuries or even single head injuries feed into risk for dementia is still very unclear, how that sits with this concept of CTE or not. And I guess, as I said, I apologize that I've ended up over speaking to the slides. The one thing, I'm just going to move on very quickly to say something very briefly about alcohol and TBI. And what I chose to do was to focus on if you drink on top of having a head injury, what kind of result that may lead to. And so I am just going to slide through my slides very quickly. I apologize for that. The main problem we have is that we do know that obviously if you have an existing alcohol use disorder, so those are people who are dependent on alcohol or misuse alcohol, you are more likely to have a head injury. That's probably not a surprise. But equally, if you sustain a head injury, you are more likely to start to drink or misuse alcohol afterwards. And so the two can feed into each other and certainly lead to a worse outcome overall. The other problem is, as you can imagine, that people who have alcohol misuse problems tend to also have a range of cognitive issues as well. And so that can cloud the presentation of head injury and cloud what is causing those problems. And on top of that, we also know that alcohol can cause alcohol-related brain damage in its own right. It may be secondary to those head injuries that I mentioned, to thiamine deficiency, or to the direct effect of alcohol on nerve cells. So the issue of how alcohol interplays with head injury is very, very complex, not an easy one to tease out at all. So to summarize, as I said, tried to bring this together to a prompt end, and I apologize for the fact I've not been able to cover everything I hoped. The bottom line is that TBI, head injury, is very common. The outcome is very varied and difficult to predict. We know that there is some link between head injury and forms of dementia, but what that pathway looks like is still very unclear. We know that people who have alcohol use disorders, both before and after having had a head injury, leads to poorer outcome. We know that we really need to have more public health interventions to address this. So one of the slides I didn't get to mention talked about the fact that public health initiatives like wearing seatbelts in cars, reducing the legal blood alcohol limit has had a massive effect on the amount of head injuries that people have had. So those kind of interventions have had real change. But what is obvious is that we still lack a lot of clinical research around head injury and how alcohol impacts on those risks. And to be frank, as a clinician, one thing I've certainly found over the years is that services do not support people well who have head injuries by and large. As I said, most of them do not present to A&E, do not go and see their GP, and yet they may continue or develop new difficulties years after. So clinical services, as clinicians, we need to think about how to adapt those, particularly if, as Simon said, we're at the point where we could be talking about preventing dementia, or at least developing treatments that could be used in that preclinical group before people actually develop the dementia syndrome. Then TBI becomes a very important thing that we need to be able to identify and ideally try and prevent where we can. So we reduce those risk factors and we can optimize the likelihood of response to treatments. As I said, again, I'm very sorry I wasn't able to cover everything, but this is a complicated problem. This last slide just emphasizes that. It's not a clear answer to this one, of course, but I hope that we can make some progress over the coming years.
Thank you very much, Vanessa. That is a great talk, and that's very kind. So you've left your email there in case anyone has any other questions. The first one, I guess, goes back to something that Karen asked, whether you're aware of any studies looking into the long-term outcomes of ECT, electroconvulsive therapy, in regards to dementia risk.
So, I mean, broadly speaking, the research that is out there suggests that there's no specific link with ECT and dementia, to my knowledge. I think you have to think often why somebody may be requiring ECT for treatment, and obviously those tend to be people who have very often very complicated presentations and may have a whole range of other problems going on, and that could include some kind of underlying problems within the brain as well. One of the points that I wasn't able to get to in my slides was the fact that one of the problems about teasing out the impact of head injuries in the progression of dementia or not is because when someone has a head injury, we don't really know whether that person already has some kind of level of underlying Alzheimer's disease or not. Unless that person has already been seen clinically or had a brain scan or something that can give us some idea, it's very hard to tell. So if over the following years they start to progress in terms of having more memory problems, it's really hard to know, is that because of the head injury or is that because they had an underlying dementia that was developing anyway? And I think the same goes for ECT. My understanding is there's not strong evidence as a direct link, but as ECT is often, for instance, used in the elderly who are very depressed, it may be that those people already have some underlying process that's contributing to the development of dementia, whether or not they had ECT. So I think that's the kind of problem with that question. It's a very good question, but I think it's very difficult to tease out what could be causing problems.
That's great. And Michael Ben asked another question that's specific to brain injury. He's wondering, can it be treated to minimize negative outcomes, or is prevention the only way to avoid its consequences? Is there anything that can be done in the acute or the post-acute phases to minimize the risk?
Yeah, so currently in terms of any traumatic brain injury, there are no specific treatments. There are various treatments that have been used pharmaceutically, but these are all symptomatic treatments. So this is about, for instance, if somebody's having problems with their attention or their memory as a result of their head injury, there are certain medications that can help with that. Depression is a really common problem after head injury, and obviously that could affect your ability to concentrate or remember things. So antidepressants are used very commonly after depression. And there's some research going on as to whether things like giving antidepressants before people develop depression after head injury may be useful. And then there's various behavioral and psychological therapies that are used post-traumatic brain injury. But unfortunately, there's no pathological treatment, if you like, that at the moment we know will change any of those progressive changes over the years. The biggest results to date have been about trying to prevent injuries occurring in the first place. So the public health initiatives around alcohol, driving risk, that sort of thing.